induction is really a key component of the transplant package for multiple myeloma. I think everybody agrees today that bortezomib-based induction should be the standard of care. And I believe in most countries worldwide, VRD, bortezomib, lenalidomide, dexamethasone, is likely the optimal approach. I do acknowledge that many European centers continue to use VTD, bortezomib, thalidomide, dexamethasone, but of course we struggle with the toxicities of thalidomide, and ideally we would like to establish VRD. With this in mind, actually the next step in terms of conditioning is the inclusion of a monoclonal antibody, namely an anti-CD38 monoclonal antibody. And I think we have emerging now and quite strong data, randomized controlled data, about the role of daratumumab and VTD. This is the Cassiope trial. So, and of course there are ongoing trials with Dara VRD. So sort of a quadruplet combination for induction. Obviously, you may wish to take it to another level and use a second generation proteasome inhibitor. And this is where one can replace bortezomib with carfilzomib. And this is the KRD regimen. And there's already some data in this field, but you can also add the monoclonal antibody, Dara-KRD. The other proteasome inhibitor is ixazomib, IRD induction, or Dara-IRD. So in summary, you can see very well that this induction component prior to transplant is also now becoming a moving target. It's likely that the next standard of care will rely on a combination of a monoclonal antibody, anti-CD38, plus a proteasome inhibitor, plus an IMiD. And this is really important because these very powerful combinations are allowing to achieve a very strong disease control prior to transplant, and in many patients, negative MRD. And this is a very good parameter for the outcome after auto transplant.